PCOS is the most common endocrine disorders in women of all ages, and adolescence is not an exception. So various like normal pubertal changes overlaps with the diagnostic criteria that is taken in adult PCOS. So it's a challenge. Diagnosing adolescent PCOS can be challenging. Let's hear more about adolescent PCOS from an eminent speaker, academician, clinician, and a teacher loved by all her students, Dr. SAREENA GILVAZ, madam. She is the head of the Department of OBG at Jubilee Mission Medical College, THRISSUR. Over to you, madam, on the talk on adolescent PCOS.
Hello. Yeah.
Yes, madam.
Hello, everyone. All the organizers of this conference, the entire KFOG faculty, Dr. Raju, who's been behind me with this, and all the other organizers. Good evening to all of you all. Now, we have been hearing so much about PCOS, but I'll tell you the most challenging thing is to talk about an adolescent PCOS. You understand there are a lot of ifs and buts about it. Now, we all know that Steen and Leventhal first described it in 1935, and they called it, there at that time, they noticed infertility and amenorrhea in 7 women, and that's how they started it. But now we have given it a lot of definition, etc. But now we say the prevalence rate with those definitions, it comes to about 18 to 13%. This is the present recommendations all over the world, that's the incidence. But if you look at in particular areas, in certain like urban, rural, etc., you might find that even goes even higher than this 8 to 13%. And in the adolescent age group, much more. Now, you know that the AES said that to say you have to have all the 3, that to say it's a PCOS, you've got to have ovarian dysfunction. Now, they say oligomenorrhea and anovulation. They both are synonymous because somebody who's got ovulation normally has a regular cycle. You understand? So that is why they always put anovulation and oligovulation as when they say ovarian dysfunction. Second is hyperandrogenism. These are 2 very important things in the adolescent. And in the Androgen Access Society, they said you should have the evidence of polycystic ovaries also on the ultrasound for you to say it. But the ESHRE in 2018 said that you need to have 2 out of the 3, clinical or biochemical hyperandrogenism. You know the meaning of that? And you see where it has gone up before the anovulation. Okay. Now that either you see clinical evidence of anovulation, or you find that when you check biochemical parameters, you find that there is hyperandrogenism. Again, oligovulation, anovulation, it's synchronous because as I told you, a regular ovulatory functions, normally they have regular ovulation, regular cycles. And the ultrasound, yes, we'll come to that. They have given a particular volume of more than 10 ml and antral follicular count of more than 20 with when you do it on the transvaginal with the frequency of 8 megahertz. You know why they have stressed that? If you take the olden days transvaginal ultrasound, which has got lesser resolution, you will not be able to pick up so many follicles. Only if you've got a very high resolution, that is why they have given this 8 megahertz. Okay. Now, to diagnose adolescent PCOS, have got all the features, but do not meet the diagnostic criteria. They say it is better to reassess. It should be done after the reproductive maturity. And they have said that before you label her as PCOS, it is like giving her a name. And once they've given that name, that has got a lot of other effects also on the girl and on the family. So it is best said that you give her that name after 88 years after post-menarche. Okay, there was even a definition earlier which said that you give her, you say a patient adolescent PCOS has got it only after the age of 18 years. But so meaning to say, don't say it very early in her adolescent life because most of them have got anovulation, right? So you'll find a lot of follicles. They have not ruptured. So you'll find a lot of follicles. That's called multifollicles. You understand? It does not account for a PCOS diagnosis. Now, they have given us some more definitions, okay? Now, the recent criteria, they have said that, as I told in adolescent girls, irregular cycles are so common. So they've said in the first year after her menarche, she can have irregular cycles. So forget about the first year. They say even up to 90 days of amenorrhea. Yes, we do see, don't we? After they get their menarche, 2-3 months, they have no periods, and then again they get a cycle. So irregular cycles in the first year, forget about it. But within 1 and 3 years post menarche, we say irregular when it is less than 21 days or when it is more than 45 days. So they've given us a definition for us to say irregularity in the adolescent. Okay, between 1 and 3 years. But after 3 years, though that looks very complicated, you need, they've said 21 and 35 days. You just say less than 8 cycles per year. That is enough. Up till menopause, when you find for you to say ovulation, oligomenorrhea, sorry, you'll have to say a cycles less than 8 cycles per year. So I think that is pretty clear now. So first year, don't give it any status. Between 1 and 3 years, less than 21 days or more than 45 days. And after 3 years of menarche, for you to say the girl has got irregular cycles, let it be less than 8 cycles per year. Okay. Now you will realize that oligomenorrhea is seen in 60 to 85%. But please remember, there is a 15 to 40% who do not show this. Do you understand? And if your patient with the PCOS shows a secondary amenorrhea, they're like say about 6 months, 9 months, she doesn't get her periods, that denotes a severe form of the disease. Please remember that, okay? Now, many times they come with HMB, which is another menstrual irregularity seen in association with anovulation. Another 10 to 15%, they even have regular menstrual cycles, but they could be anovulating. So it is said now in the recent guidelines, if you want to say she's anovulating, even though she's got regular cycles, check the mid-luteal progesterone levels. So everything is very clear. So we don't have many doubts about many of these definitions. And okay. Now, when a person comes to you with this, we always know that there is an element of hyperandrogenemia. So we often give a combined pill with the cyproterone or drospirenone, because cyproterone, has got a very potent anti-androgenic effect. You can't give it alone. You can't give just a plain cyproterone because her cycles will go haywire. So we always combine it with an estradiol, and it's always combined with the 35 microgram estradiol. That is why we got Crimson, Dan, 35, many things, everything there's a 35 micrograms of ethinyl estradiol. The drospirenone, as all of you all know, it has got anti-androgenic effect. It has also got an anti-mineralocorticoid effect, okay? Because it's a derivative of spironolactone, okay? So those are the two combinations when we want to give a PCOS patient. We give an anti-androgen because we know there is a hyperandrogenemia. Now, today they say that if you want them to regularly menstruate, we all know she's got enough of estrogen. So what she lacks is ovulation and so progesterone. So you can give progesterone 12 to 14 days. Earlier on, we used to say give it once in 2 months so that she has to bleed at least once in 2 months. But now the recommendations say you can give it even every month. So you can just give it in the second half of the cycle. You can just give her a progesterone. So that is another way of treating her irregular cycles, okay? Now, ovulatory dysfunction, what is very important in this is, whenever we say in PCOS, the cause is in the ovary. I want the take-home message for all of you all that. If the anovulatory is due to some other cause, it's not PCOS. Do you understand? So we do find patients having hypothyroidism and ovarian dysfunction. Then you treat the thyroid and she will ovulate. It is not PCOS. Do you understand? She's have a hyperprolactinemia and she can have irregular cycles, etc. You treat the thing with bromocriptine or cabergoline, etc. If a drug-induced one, suppose she's been on danazol, androgen, progesterone, valproic acid, anabolic steroids, in all these conditions, they can have anovulation. Withdraw the drug and see it is not PCOS, okay? So you must have an ovarian cause, not ovulatory, ovarian cause for the ovarian dysfunction. Now, when you say when you talk about other androgens, we say non-classical adrenal hyperplasia. Now, this should be ruled out. These the following 4 which I have given should be ruled out before you say the patient has got a hyperandrogenemia due to PCOS. So the classical adrenal hyperplasia is seen at birth. And that you see during the adolescent age group is called the non-classical variety. The androgen secreting tumors of the adrenals, the Cushing syndrome can cause hyperandrogenism. The androgen secreting ovarian tumors can also cause. So all this should be ruled out. That is why we investigate in a person who comes to us with hyperandrogenemia or with anovulation, okay? Now, please remember, all along I've been telling you hyperandrogenism, and that is normally equated with hirsutism or acne or hair fall. That is that is a milder form, okay? But the very severe form is called virilization, which is never seen in PCOS. So if you see a woman who's got temporal balding, or she's got hoarseness of voice, or a muscle mass increase, or clitoromegaly, then you look out for other androgen secreted. So basically androgens are secreted from two sources, ovarian and adrenals. So rule out other causes, because we know that the adrenal androgens are under the effect of ACTH, the ovarian androgens are under the effect of LH. Okay. Now, when you talk about non-classical adrenal hyperplasia, even today I saw a patient full of hair. She was looking like a chimpanzee. Okay. So it is good that you check out. This could be late onset adrenal hyperplasia. And the only thing that you need to check out is 17-hydroxyprogesterone. The normal values less than 200 excludes a diagnosis. If it's more than 800, it confirms the diagnosis of adrenal hyperplasia. But if it's between these two, you must do an ACTH stimulation test. So these are all the tests, as I told you again and again, rule out other causes before you say she's got a PCOS, okay? Then, of course, you image to see whether it's an adrenal tumor, or you can do high levels of DHEAS, because DHEAS is actually secreted only by the adrenals. So if that is high, that means it's an adrenal cause and it is not PCOS. You understand? Cushing's, check the serum cortisol. Then, of course, the ovarian androgen secreting tumors, check the serum testosterone, do the imaging, that will tell you more. So by all this, we have ruled out the other causes. So we do ask for a lot of investigations. That is in order to rule out before we confirm PCOS. Okay, that's so it depends upon the situation. You don't have to ask for all that as a routine, but play your cards according to the situation. Today, we say that PCOS is familial, and there are various aspects of the syndrome being differentially inherited. Premature balding is a male phenotype. So if there is a girl who's got PCOS in the family, a brother could have premature balding. Okay, that is what is meant. Now, I just want to go to the basics a little. If you look at that follicle over there, you all know that there's a granulosa cells, a granulosa compartment, and the outer part is the thecal compartment. Okay, so the thecal compartment is the androgen compartment of the ovaries. The granulosa cell, etc., is the estrogenic compartment of the ovaries. That all of us know. It's called the two-cell theory. Okay, the granulosa cells are under the effect of FSH, and the theca cells are under the effect of LH. So, in other words, under the effect of LH, the theca cells in the ovary, they secrete androstenedione and testosterone from cholesterol. Okay, they are the two normal androgens which are secreted by the ovaries under the effect of LH. I told you some time back, the androgens in the ovaries are under the effect of LH. Okay. Now, if you look at the diagram, I'll just move my cursor, because when I move my cursor, sometimes the slide moves. So you saw this. I'm sorry, I knew that. Okay. So when you see my, I don't know where my cursor is. Okay. You see that there is a basement membrane all around. Beyond that is a thecal compartment. And that, it goes on to form the stroma. That is why we say the LH-FSH ratio when it is raised, because we know there's the ovarian androgens are raised under the effect of LH, and so we always find the LH more. And the FSH, which is by the granulosa cells, all of them are multiple follicles. They don't attain maturity because the FSH is less. So earlier on, we used to say LH-FSH ratio. Yes, it still holds good, but it may not form one of the criteria for you to define. But if you find it well and good, it adds on to your diagnosis. Please remember that. Now, if you look at the present morphology, they say, don't look at the stromal increase. But if you see a stromal increase in the ultrasound, it adds on to your diagnosis. We know that there's an ovarian androgen excess. I hope I've made myself clear. So if you look at this, you see the FSH. FSH is less, and so the follicles, multiple follicles, so you get that typical, the old necklace pattern we used to say. The LH is more, so the stromal compartment is more, and because of that, androgens of the ovaries are more, which I told you, androstenedione and testosterone. But what do these do? They go to the periphery, the extraglandular conversion or aromatization, and it forms estrogen. Do you understand? So that estrogen keeps on badgering at the higher level, and it keeps on increasing LH. Okay, there's a positive feedback on LH and a negative feedback on FSH. Do you understand? So the cycle goes on and on and on. So the ovarian androgens are increased and the peripheral conversion is also increased. So actually the estrogen levels are increased, but you will find because of that, it produces a negative feedback on FSH, and so FSH becomes down and down, and it increases the LH more and more, and you get more and more amount of ovarian androgens. So those of you all are interested in the pathophysiology, that's exactly what it is. So low levels of FSH is due to the negative feedback. Plus, you will find that these small follicles also secrete a lot of inhibin. Do you understand? So that further suppresses the FSH. You understand? So the high levels of estrogen, negative feedback, plus the high levels of inhibin reduces the FSH level. So that is the basic pathology, that the FSH is less. Now, when you look at the ovarian morphology, you find, now we say that there should be 20 or more follicles, but I told you, it will have to be a high resolution transvaginal ultrasound with 8 megahertz resolution. 2 to 9, because more than 10 millimeters, we say she's got a dominant follicle. So a dominant follicle is one which becomes that, becomes ovum in that particular cycle. Do you understand? And which ruptures and later becomes a corpus luteum, and then you get progesterone. So in this case, there is anovulation, and so no corpus luteum, no dominant follicle. Now they have said the present criteria, the arrangement of the follicles can be haphazard, it doesn't matter. It can be in one ovary, it doesn't matter. Increased trauma is not required. But if you see all that, let me tell you, it adds on to your diagnosis. So features of androgen excess is seen in the form of excessive terminal hair, because there are 4 types of hair as hair grows. And you'll find that is the earlier hair is the villus hair, and the terminal hair is the thick hair. Okay. So excessive terminal hair of the male pattern seen in the 9 body areas. Okay. The upper lip, chin, chest, upper back, upper abdomen, lower abdomen, and the upper arms and legs. It's not the lower part. Okay. Now, if you find, and then you scale between 0 and 4. The 0 is the villus hair and 4 is the terminal hair. That's how we give the staging of modified Ferriman Galvez. And today, look, before we used to say more than 8, right? To say hirsutism, but now it has gone down to more than 4 to 6. But it varies with ethnicity. Do you understand? But if you see a score of 4, that itself tells you there's hirsutism. Do you understand? And acne, there is another form of hyperandrogenism. There is no scoring. But if there is alopecia, there's something called the Ludwig's visual score. Okay. But normally we don't see alopecia so commonly in the PCOS patient. But I also want to tell you that girls report with excessive hair fall. That excessive hair fall, let me tell you, you don't have to measure anything. It tells you excessive androgens. So as I told you all, there are 4 androgens in the body. Okay, testosterone. Okay, then you've got androstenedione. Then you've got the DHE, dehydroepiandrosterone, and the dehydroepiandrosterone sulfate. And there are only 2 sources. One is adrenal cortex and the ovary. There are only 2 sources of androgens. Do you understand? So, and I told you all DHEA is 100% is from the adrenals. So if you want to know the adrenal source of androgens, just check DHEA is more than enough. Do you understand? So now coming to what I was telling you all, the DHEA, the DHEAs, the androstenedione are really the weak androgens. Okay, they may be raised and she may have acne, but when you find that you got the terminal kind of hair, etc., is a testosterone, and that testosterone, you know, is converted by 5-alpha reductase to dihydrotestosterone. And it is a dihydrotestosterone which is responsible for converting the villus hair to terminal hair. You understand? So we see the terminal hair. So you can check out for terminal hair. Now there's another thing about the testosterone, okay? 80% of the testosterone is bound to sex hormone binding globulin. It is very potent androgen. 80% is with globulin. 19% of testosterone is bound to albumin, and only 1% is free. That is why, and it is this one which is free and is biologically active. You understand? So to demonstrate the presence of hyperandrogenemia, the free testosterone levels is the best marker. But it is so difficult to get a good testing, an analysis of a free testosterone. So normally we ask for the total testosterone, okay? So the biochemical hyperandrogenism needed to be checked when there is no clinical hirsutism. Okay, she's got all the features and you suspect maybe high fall, etc. But there's no clinical hirsutism. You can check it. And what do you check? You check the free testosterone or the free androgen index. And that they say now, they've added on a few more. The type of assay which you should be doing. You should be doing the liquid chromatography. You can do the mass spectrometry, or you can do the chromatography immunoassays, which is required for accurate assessment. Earlier on, they were doing the radiometric and the enzyme linked assays. They say that those 2 assays are poor sensitivity and accuracy. So if you can get these tests, you know, the liquid based and the mass spectrometry and the chromatimmunoassays, if you can do your testosterone, if that is available, only then ask for the free testosterone. If that is not available, let it be the total testosterone. Now, hirsutism, hair removal is very good. Waxing, they can pluck, they can shave, they can do depilation, electrolysis, laser therapy. Let me tell you, the laser for the, it may be done only for the facial hair. It's a diode a laser, which is a very weak laser, and you can prescribe it to all your girls who come, because whatever treatment you give, that hair will not go unless you have done some kind of therapy. So let her go to the parlor and do it. They'll have to have 3, 4, 5 sittings of laser therapy for the upper lip and for the lower lip and for the chin, and it is taken care of very well. The legs and hairs, who looks at? Nobody looks at it. Okay. Now, if she is worried, you can give a cyprotron drospirin. I heard some of you ask about cyprotron, whether it can produce venous thromboembolism. Yes, long-term use of cyprotron can produce venous embolism, according to present-day studies. So the best thing is you can't give an androgen. Yeah. So you can't give a plain cyprotron. It should always be coupled, because I told you the menstrual cycles will go haywire. So the drospirenone also combined with ethanyl estradiol, but it is 30 micrograms. It regulates the menstrual cycles. It takes care of your acne. Acne, which is resistant to any form of treatment, you can do that along with, you can give the samosi pills with these combinations, and they are so happy with you. They will tell you they've gone to the dermatologist for so many months. It did not help me, madam, but your drug for 3 to 6 months, all my acne have gone, because you have reduced the androgen levels. Do you understand? The hirsutism, yes. And then, of course, you'll have to give these pills also to reduce the endometrial hyperplasia. And also told you can give progesterone every month. So these are the combinations: ethanyl estradiol drospirenone, ethanyl estradiol cyproterone. Then another androgen which you can give is spironolactone, but we normally cannot give it for very long because it's a diuretic. Do you understand? Flutamide I've written across because of its liver toxicity is no more given. But if you ask me, yes, I give finasteride. I give sometimes in girls who are not married. I give finasteride when the androgen levels are very high, and it is a 5-alpha reductase inhibitor. So you understand now? It reduces the testosterone conversion to 5-hydrotestosterone. So it's very good. You can give it for 6, 8 months, 9 months. It doesn't matter. Nothing happens. And then, but once she gets married, you better stop it. Okay. In case she becomes pregnant, you had your problems. Then you can give Hinder, eflornithine. Okay. Now this, I want you all to know, it is there in the market. This anti-metabolize is a topical cream, and it is applied twice. You can apply it over the upper lip and the chin in affected areas. It's applied only over the face. Okay. It is an irreversible inhibitor of ornithine decarboxylase, which is responsible for hair follicle division and function. But remember this, you remember its inhibition, it slows the growth. It does not stop it. So she will have to do her hair, shaving or waxing or whatever she does. But she can also apply these twice a day. It does not permanently remove hair. It only slows the growth. But there are many people who ask and come for this, and I give it to them. Okay, it's available in the market. Routine removal of hair for method should also be done along with this. Now coming to the next problem of acne. Acne, there's a blockage of the follicle because of the hyperkeratosis. There is sebum overproduction, there's proliferation of the commensal, and there's inflammation. So that's how the acne, we say more than 10 comedones is very significant acne. Okay. So what do you do for acne? When she comes to you, she can apply the benzoyl peroxide. It's a bactericidal drug. You can give her topical antibiotics. You can give, if it is infected, give her the, typically we give erythromycin or clindamycin, which is a topical antibiotic. But if you want, you can give her the oral antibiotic for the acne, which can be doxycycline. It's minocycline and erythromycin. Give it for about 10, 14 days. She's fine. All those infected ones will all subside, and then you can. Now the oral isotretinoin. This is very, very effective. I hear that film stars use it before they go for they've got a lot of pimples, and it's very fast acting. It treats the severe recalcitrant acne. It is teratogenic. Please remember, it is teratogenic. If a person has had this in the first time, used it as a topical cream in the thing, and if she has used it oral also, you will have to terminate the pregnancy because because it can produce cranial, facial, CNS, thymus, all this it can produce, and therefore it is to be used with the contraception. Please remember that, okay? Very, very important. Amma, ipo eniki pattilla. Insulin resistance. Now, why do I talk about insulin resistance in the patient with adolescent PCOS? Because adolescent PCOS has got hyperandrogenism. And I always say hyperandrogenemia and hyperinsulinism, they walk hand in hand. So if she has got a hyperandrogenism, she is likely to have insulin resistance. Please remember that. Therefore, we see many of these girls who come to the OPD, they've got acanthosis nigricans, which is clinically seen, you all know, as velvetish discoloration seen on the neck, axilla, under the breasts and groin. Hyperinsulinemia stimulates the keratinocyte and fibroblast growth. That's where they find skin tags. That is again an evidence of insulin resistance. Okay. Then, as I told you all, there is an association between hyperinsulinemia and hyperandrogenism. So much so, if you give, I heard a lot of conversations going on with you all. If the patient is a very obese patient with evidence of insulin resistance, you treat that and it will reduce the androgen levels. Okay, it does reduce the androgen levels. Evidence suggests that this insulin resistance is responsible for the PCOS later on going for the metabolic syndrome. Okay, so you will have to treat patients who have got evidence of insulin resistance. It's now routine screening for insulin resistance is not done. We don't check the insulin levels. We don't check the fasting glucose insulin ratio. All that is not done. Instead, if the BMI is more than, we used to say 30, now they've reduced it to more than 25. Then you can ask for a 2-hour OGTT and you can check out. And these are the values. You see that last column, which I've written diabetes. If she's got a HbA1c of more than 6.5, or if she's got a fasting more than 126, or she's got a 2-hour postprandial, 2 hours following this, she's got more than 200, it is diabetes. If it becomes between 5.7 and 6.4, that is HbA1c, or between 100 and 125, it is impaired glucose tolerance. And if it is between 140 to 199, 2 hours. So you just see what it is. It is available. You all can take my slides at no issues. Now, metformin. Metformin is a drug which we give when we see. You know, it's a biguanide derivative. It decreases hepatic glucose production. That's the most important effect. Yes, it improves peripheral utilization. It's more lipid friendly, etc. We start off with 500 up to 2000. Slowly increase it because if you give it suddenly, she's got GI symptoms, abdominal bloating, and the worst thing is the metallic taste. But normally, as you keep on giving it for a long time, she gets used to it and she accepts it. But lactic acidosis, no, it's very rare. It's very rare. Only if she's an alcoholic or she's got a renal dysfunction or she's got a cardiac problem, etc., you get lactic acidosis. Now, when you look at your obesity, you see the picture on the left and on the right, you see a pear shape. That's how we draw a girl. We draw a girl who's got a waist is slim and she's got wide hips. That's how it should be. But the one on the left who's got an apple, that is central obesity. That is bad. That is bad. So if you find a woman who's not only obese, who's got central obesity, meaning she's got a pot belly, a codavira, that is bad. That is central obesity. She's got the metabolically active fat. She's more prone for CAD, etc., so on. So normally a girl, I always tell them, why don't you do your normal waist hip ratio and see? It should be less than 0.85. That means her waist is small and her hips are big. You understand? That's how it should be. So obesity worsens ovulatory dysfunction, worsens and hyperandrogenism and acanthosis. And so what you advise is regular exercises. And this is the best way you can advise, okay? You'll have to tell her something. You just don't give her a tall order and say, reduce your weight. Tell her a target, tell her what to do. An energy deficit of 30%. If she doesn't understand that, you tell her, reduce whatever calories for your weight you've got, reduce it by 500 to 750 kilocalories per day. In other words, she should be on the negative side. She doesn't understand that also. Tell her, you should have a diet which has got only about 1,200 to 1,500 kilocalories per day. Okay, she understands that. Then you must tell her, diet alone does not reduce. You must do physical activity also. Just doing even 60 minutes of moderate to vigorous physical activity. You know why that vigorous and more, it's important because I see people walking on the road, they walk high. That's of no use. It only keeps you fit. It doesn't reduce your weight. So it should be vigorous physical activity. Plus, you must tell them muscle and bone strengthening is very important at least 3 times a week. That is your dumbbells and weights, etc., etc. She must do that. Only then, otherwise, when she loses her weight, she will look very haggard. You understand what I'm saying? She will sag. So you'll have to tell her that. And another one, very important, many of them have got the Fitbit now. So everybody talks about 10,000 steps per day. Yeah. She doesn't understand that. Tell her, you do 10 minutes and do 1,000 steps for at least 30 minutes every day. So she does say about 3,000 steps. That is another way of telling her how she should reduce. Obstructive sleep apnea is related to central obesity and insulin resistance. So many of them, you send them for sleep studies, they are prone for CAD later on in life. So women with PCOS have got a 30 to 40% higher risk of sleep apnea and a higher risk of diabetes and coronary artery disease. Various psychological, that's the biggest problem I've seen. They are anxious, they are depressed, they're low self-esteem, reduced quality of life, negative body image. Natural, she's come so fat, even, she's come with 120, 130 kgs. What is her self-esteem? It is so poor. And you have to pep it up as a doctor because they're adolescent children. Do you understand? They're adolescents. Laparoscopic ovarian drilling not done in the adolescents. Okay, bariatric surgery not done unless, and not done in adolescents for sure, and only in BMIs more than 40, even in the adults, and that is a sleeve gastrectomy. So 2 no's, no bariatric surgery, no LODs in girls. A weight reduction, yes, we often tell them 5 to 10%. That's all what we have learned so long. But remember, that is within 6 months. You've got to give them your weight reduction of 5 to 10% is within 6 months. So you come back after 6 months, let me see your reduction 10% weight. Supposing she's 80, you reduce 10% of that and let her come back to you. That's what you should tell her. So lifestyle, a diet low in saturated fat, high fiber, low glycemic index. The addition of insulin sensitizers help in reduction and the morbidity associated with metabolic syndrome. Not for weight reduction, you should not give it. Now, this is my last slide. So friends, in an adolescent, weight loss and exercise. Now, you know how to advise them. A healthy approach to it. They should not starve. They should not starve. They should exercise. It should be moderate to vigorous exercise. They should do muscle and weight bearing exercises. Otherwise, they will sag and they will look ugly. You can give COCs, reduce the androgen levels. Give for about 3 to 6 months. Fine. If she's got a chronic, thing, they can add progestrogens, maybe in a little older age group. Insulin sensitizers only if she's got evidence of insulin resistance, which is seen as obesity 1, acanthosis nigricans 2, central obesity or a pot belly, and skin tags. That is the clinical evidence. You can do others. You can do the OGTT, as I told you. You can give anti-androgens. I told you don't give anti-androgens. You can give finasteride. It's fine. 5 milligrams you can prescribe. Or you can give the OC pills. But OC pills we normally give for about 3 to 6 months. Topical treatment for acne, and I told you how to do it. You can give the benzalbens. You can give also the topical antibiotics, or you can give them the, if it is infected acne, you can give them the systemic antibiotic, already told you 10 to 15 days. And excessive hair, again, if they want something, you can give the Hinder, or you can give the isotretinoin. But remember that you should not become pregnant during this time. So let me tell you, my last advice to all of you all is this. When a girl comes to you with just about 8 to 12 cycles, she's got mild hirsutism, and she tells me, Madam, they told me it's a PCOS. Let me tell you, just leave her alone. She doesn't require your treatment. You must tell her, my young little girl, this is nothing for you to be worried. You don't have PCOS as of now. Let us see how you reform yourself, you reduce your weight, etc., etc. But remember, ask her to come back to you, because you should not miss out. She may develop later on diabetes. So on and on, tell her come back. Let me see, and weight or new, etc., etc. You just do some pet, but don't dub her as and adolescent PCOS. So my plea to all of you all is don't overtreat. Thank you.
Thank you, SAREENA madam, for the clear, crisp talk on adolescent PCOS. Actually, thank you for stressing the psychological aspect of that psychological support that we have to give. And shall we move on to discussions?
Yes.
Bindu madam, are you going to ask? Or?
Yeah. Sir, for a few questions to you, Mohan sir. Can I ask you? Hello.
Mohan? Yeah.
One question is, clomiphene citrate plus letrozole. What is the risk of multiple pregnancy? Any data on that? Combination of clomiphene citrate and
that's a very, these are very early studies. So as I said, there's only one trial, and they have not had a pretty high multiple pregnancy rates. But that's one of the side effects that we probably will have to look at. So I would suggest right now it's experimental, this protocol, and it has to be done under controlled circumstances. Like we are doing a trial, so under trial only we are doing. And the preliminary results do not suggest an increase, but I would say they are in single digits right now, the pregnancies. So we'll have to wait for the multiple pregnancy data on this probably, and then only look at it. So caution for all, it's not for routine use right now, this protocol. Yeah.
Okay. Any role of adding metformin in clomiphene resistant lady planning for letrozole?
Yeah, so metformin probably had its use more when letrozole was not around. And then we routinely used to put patients on metformin if they were found clomiphene resistant. We used to have an extended 6-month session or so on, and then move on again to clomiphene HMG. But there is very less data on should we add metformin and then move on to letrozole combination, because there's hardly any trial looking at that. I would probably stick to directly going to letrozole than going for metformin and then going.
Another question, using letrozole and HMG in sequential regime, what is the dose of letrozole and HMG used to avoid multifollicular development in a patient with clomiphene failure?
So we can use both either 2.5 or 5 milligrams. You could keep it lower, 2.5 milligrams from day 2 to day 6, and add HMG 75 units from day 5, alternate day, day 5, 7, and 9, and then do the scan on the 10th day and accordingly add gonadotropin if you need to reach the optimum site. So day 2 to day 6 letrozole, 2.5 milligrams, day 5, 6, day 5, 7, and 9, the HMG 75, and then scan and take it forward. Yeah.
I think there are no more questions to you. I'm handing over the mic to Dr. Sati.
Thank you.
Thank you, sir.
SAREENA madam, one question is there. What treatment do we suggest for young unmarried PCOS? That you have said last in the summary, that slide. So just summarize. Madam, just summarize for that is lifestyle modification.
Yeah. See, PCOS should be treated like a cafeteria approach. You know what that means? Supposing she comes to you with acne, treat only her acne. Don't worry about anything else. Just leave her alone. Do you understand? If she comes to you with irregular cycles, you treat her irregular cycles with OC pills, etc., for 3 to 6 cycles and be done with it. She comes to you with hirsutism, you tackle the hirsutism. I've given you a whole lot of things to choose from.
Yeah.
See what the problem is, and then if at all, you can't give long-term OC pills. Do you understand? And you can't give them. So you try, as I told you all, I told you many things. The best I would say is a diode laser for a facial hirsutism in a young girl who's going to get married, etc. And along with that, if she again has a problem, you can ask her to use, do the waxing, etc., etc. So let her do whatever. Don't put everything under treatment of drugs. Don't give them that, okay? And that to an adolescent PCOS doesn't require anything. So even that a few irregular cycles, you can set it right by giving her 3 cycles of whatever your cypritone, drospirenone combination. She'll become okay with that. Then she will not come back to you. And tell her that, you know, I always tell them 1 or 2 more things. Tell them when you get married, don't plan too much. Okay, I tell them don't plan too much. ചില ആൾക്കാർ പറയും ഞാൻ MSc ചെയ്യണം, അത് കഴിഞ്ഞ് PhD ചെയ്യണം, അത് പിന്നെ വീട് കെട്ടണം, അതൊക്കെ കഴിഞ്ഞ് മൂക്കിൽ പല്ല് വന്ന് കഴിഞ്ഞിട്ട് when she think of, then I'll tell her already you realize you become too, your chances were less and you have made it much less by doing all this. So knowing that your chances are less, try from day 1 for pregnancy. I always tell them that. Second thing I tell them this, നിങ്ങൾ കല്യാണം കഴിച്ച ഉടനെ അവർ അമ്മായിമ്മയുടെ വീട്ടിൽ പോകും, you'll put on a lot of weight. Don't buy a weighing machine and check your weight daily. I don't know whether I'm overdoing it, but if you check, you know, that is just to put in that concept into the mind that weight gain is the most important. I still remember, you know, years back, I had gone to Vellore, Dr. Mohan. I'd come to Vellore for a conference on PCOS. The whole day the conference was on PCOS, okay? There were a lot of international speakers and all that. And, you know, I had only one take-home message in that. At the end of the day, I just told myself, what did I learn today? There was just one message: weight loss. And that has not changed through all these years. That has not changed. So I'm telling you all, you highlight that. Now, you can't tell a person who's 140 kgs, go and reduce it and make it 60. Where will she do that? Where will she do that? But you can tell them inspiring stories. No, I had a neighbor who was a Russian, okay? Her weight was 124 kilos. And then I used to see her very often. I used to tell myself, oh gosh, I don't know when she'll come to me saying that she wants to become pregnant. Then after several months, I saw her. She had lost 44 kilos. Believe it or not, she came to me with 80 kilos. And then I said, what happened to your weight? She said, I knew you were going to tell me to reduce my weight and come to you for infertility. The first cycle of ovulation induction, she became pregnant. The credit is not to her, it goes to me. I did nothing. It was her weight loss, but I got the credit for it. She even goes on telling, oh, Dr. SAREENA made me, I did not, it was her weight loss. So that's what I'm trying to tell you all. Highlight that in whatever way you form, not by medication, not by thing. Give her a protocol. See, I'll give you this. 3 മാസം കഴിഞ്ഞിട്ട് എൻ്റെ അടുത്ത് എന്തോരം വെയിറ്റ് കുറഞ്ഞു നോക്കാം. അത് കഴിഞ്ഞ് 6 മാസം കഴിഞ്ഞിട്ട് then some of them will tell me, madam, I've got some night shift, this thing, that thing. I'll come to you after 6 months. So I'll tell them, this is your weight loss. So now you know 5 to 10% losses in 6 months. So give them a goal. See, they are young girls. Give them a goal. They will achieve it. That's what I'm saying.
Yes, ma'am. Thank you, madam. Then how long to treat adolescent PCOS? That is a next question.
You don't have to treat.
Yeah.
Unless she's got a problem, don't treat.
Okay. Madam, often we find patients like some weight loss will be there, but they won't stick on to that. And ossiples, after stopping 3 to 6 cycles of ossiples, and they come back with irregular cycles. So what to do in such a case?
Yeah, I'll just tell you a few tricks which I play, okay? Now, if that patient has got evidence of insulin resistance, I don't first of all give them ossiples. I know, I told you insulin resistance, clinical evidence.
Yeah.
In adolescent girls, I mean, a little more than that also. When they're very obese, they've got acanthosis, and they've got a pot belly, etc. I sometimes give them only insulin sensitizers.
Okay.
എന്നിട്ട് പറയും 6 മാസം കഴിഞ്ഞിട്ട് വെയിറ്റും കുറഞ്ഞിട്ട് വന്ന് പറയും. അതും കുറയും ഇൻസുലിൻ സെൻസിറ്റൈസേഴ്സ് ആൻഡ് ഷീ ഈസ് മച്ച് ബെറ്റർ. ആൻഡ് ടെൽ മീ 6 മാസത്തിനുള്ളിൽ ഡോക്ടർ എൻ്റെ സൈക്കിൾസ് എല്ലാം റെഗുലറായി. ഐ ഡിഡ് നത്തിങ്. വാട്ട് ഈസ് ഹാപ്പനിങ് വാസ് ഐ ഹവ് റെഡ്യൂസ്ഡ് ഇൻസുലിൻ. I've told you the androgen levels also go down, and like that slowly many of them get corrected that way. Do you understand? So that's what I'm telling you. Try to play with your drugs. Don't always over treat them. And then if they don't have evidence of insulin resistance, don't give them metformin. Should not give them.
Okay.
So I clinically tell you again and again and again. I've told you the evidence of clinical evidence of insulin resistance. Only if that is there, treat them. Otherwise, don't give them metformin.
Okay.
But I'll tell you one more thing. That Mohan Kamath is there. The time that you must give metformin is when she's got evidence of insulin resistance with infertility. Add on your metformin. It helps. Along with your ovulation induction and the metformin, she'll become pregnant.
Okay, ma'am. Next question is a girl who achieved menarche at 14 years and no periods for 8 months after that. Do we intervene or wait? Or how many months we can wait? That's a question.
I will not intervene. You know what I do? I normally give them some iron pills and I send them back. After about 1 year, she said, Doctor, I have guli edi thandile appra ella masakulum sheriyai. All what she required was just a maturation of a hypothalamo-pituitary ovarian axis. And what did I give? Only iron. That's all that is required. Please don't over-treat. And it has also been said by the recent guidelines that don't prescribe the OC pills unless 8 years after the menarche. You understand what I'm saying? So because you may put a stop to their height by closure of the epiphysis. You understand? So just play with your drugs. You play with your language, your gift of the gab. Okay? You play with that. You can talk to them nicely. Encourage them. Never put them down. Never, ever put them down. They have come to you because they are so distraught. So let not your advice be something like, yo, don't do that. Okay?
Next question is a 16-year-old girl with BMI 45, amenorrhea with hirsutism, severe back pain and inability to do even moderate physical activity. How do we manage?
It's a very big question. Now, when a person like this, if she's 45 BMI, I'll send her to an endocrinologist. The only thing I'm very smart, because let there be an endocrinological problem ruled out in her. Do you understand? Send her there, but then don't give up on her. Tell her, then you send her to a dietitian, then you send her to a physio. Let slowly, within her means, she'll be able to do it because it's a gone case. 45, what can she do? Yeah. Can she move? She can't move. And then what happens? A backache, then they'll go in for problems of the knee. They'll go in for backache. It's all a vicious cycle. So I'll say in a person like her, I would give her off to the endocrinologist.
Madam, one last question. That is, one delegate has asked, I have read in an article that PCOS can be of 2 different types. One is in metabolic pathway error, more due to lifestyle disorder, and the other is reproductive pathway error, more likely to be genetical. How can you elaborate this statement?
Yeah,
Madam?
both are correct. Both are correct. Today we do not know. We say that is actually, it could be a polygenic. It could be due to a genetic problem that we see it in families. We see it even due to wrong eating habits, and that can give rise to, it may not be the same genetically manured thing, but it can also give rise to anovulation, etc., etc. So you can always tell them that both are linked. Both are linked. There is a thing, as of today, we do not know the cause for it. But remember this one statement, that this is perimenarcheal. You don't see a PCOS for the first time in menopause or perimenopause. There will always be a story at menarche. It's always perimenarcheal. Okay, its origin. Maybe it didn't require treatment, etc., etc., but it should have had its roots then.
Right. Madam. Thank you, madam, and Sir Kamat sir, for the excellent session talks in the session. Hand over the mic to Dr. Raju.
Thank you.
Thank you.
Okay.
Thank you.
Okay, I think we'll come to the final session, and it's a panel discussion. Myself and Dr. Fessy is moderating the session. I invite Dr. Fessy